Um, so this webinar is to share some information with the community about options for bladder and bowel control. It's a significant issue for a lot of folks. As many as 44% are just too embarrassed to even bring it up with their doctor so they can try to get some help. And more than 50% say that they've never been brought up at all. They haven't discussed any aspect of it. So, this issue can impact people's lives in a fantastic amount of ways, from everything, knowing where every bathroom is between here in the cities, or where every restroom is with the restaurants they go to, being worried about embarrassing themselves out in social situations, and therefore cutting back on their social activities. It has a huge impact. So it's hard to know what's normal and what's not, especially if you haven't talked to other people. But typically, if you urinate a lot, it's going more than about 8 times a day. Having the really strong urge to pass urine that is either difficult, uncomfortable, or sometimes impossible to hold. Trying to plan your activities around when you need to use the restroom, and sometimes even holding blood pressure pills that have a diuretic in them to go to the doctor office or church or some other activity. Cutting back fluids is something that a lot of folks also do, which can be dangerous if they allow themselves to get really dehydrated. Pads are often used to give a little more confidence and hopefully stay dry, but they can be uncomfortable. They can cause skin irritation. They're a nuisance, and they're really expensive. And also getting up a lot at night, and that's a big issue for a lot of patients of mine. It can be really disruptive for their sleep and rest and overall well-being if they're frequently getting up to use the restroom at night. So it's important to know that this is not an uncommon issue. It's not just common in my practice because of the kind of patients I see, but it's very common out in our community. So don't feel bad, don't feel alone. If you need help, there's help available, and it's often important to get help because these problems can also lead to loss of sleep, loss of confidence, feeling badly about yourself, and maybe not getting other medical care that you might need just because you're really kind of prone to pulling yourself in when you feel like you can't be confident going out and doing the things that you want or need to do. So the good news is you don't have to live like this. There are options out there, and we're going to talk about a couple in particular this evening. So we can go ahead and get started. So what causes bladder and bowel problems? It can be habits like what you eat and drink, sometimes medications. I've already mentioned the water pills are a big culprit. And then things that can eventually lead to bladder or bowel problems can be history of pregnancy with childbirth, pelvic floor injury, and other medical conditions that can allow weakening of the pelvis or overactivity of the intestines and bladder. So how does it work? Well, the brain is the major control center. It controls everything in the body, including the bladder. When the bladder gets full, it sends a message to the spinal cord that the bladder is full and it may be time to empty. But the brain is able to put the brakes on the bladder and say, no, not yet. You're not an appropriate place or time to do it. So the bladders be able to be held. But sometimes that braking system can go awry and the bladder can be overactive. And that's when it sort of gets what people say is having a mind of its own, where the bladder is ruling you as opposed to you telling the bladder when it's time to eliminate. And same thing with the bowel. The brain and the spinal cord are integral in controlling the rectum when it's time to defecate. And there are times where the urge to move the bowels is so strong that it overrides the braking system of the brain, and defecation happens without you wanting to do that. For urinary control problems, there are three major issues that I encounter, and they can be a little challenging to sort out when someone comes to see me and they say, I've got a bladder problem, or I'm wet, because I need to know why they're having these issues and in order to know what may be the best treatment for them. So the first example on your screen, stress incontinence, that is more common in women, but I sometimes see it in men as well, especially men who've had pelvic surgery before, like removal of the prostate gland, for example. But that is the kind of leakage where the bladder is not the culprit, it's the outlet. It's the urethra that is allowing urine to leak out. So that's where people report leakage when they move a certain way with straining, like coughing, lifting, laughing, jumping, that kind of thing. So the pelvic floor or the muscles that wrap around the urethra to squeeze it shut when you're not wanting to urinate, that is the issue for that kind of leakage. Urinary retention is where your bladder is just too full and you can't empty it. And at a certain point, the bladder will hit maximum capacity and sometimes the urine leaks out. That's especially more common at night when the body relaxes during sleep. And sometimes placing a catheter is needed to empty the bladder. So one of the tests that I do when I see people, especially men, because their anatomy is much more complicated and prone to retention than women, is just to do an emptying check, a little mini bladder scan in my office to see if they're empty. And it's quick, it's painless, and it's really helpful for me to know that they're emptying well or not. And then finally is overactive bladder. And that is where the bladder is the culprit for people having to urinate often and having such a strong urge they can't hold it and they leak the urine. Sometimes people say that they're in the car and they know they're getting close to their destination and their urge gets worse and worse as they get close to that destination because they're anticipating running in from the car and going and using the restroom. Sometimes washing the dishes. They're at the sink, they're washing the dishes, their hands are wet, they're hearing the running water, and they got to stop what they're doing and go run to the restroom then as well. And then, although I'm a urologist, one of the things we're going to talk about tonight is a treatment that also has benefit where people can't hold their bowels. It's called fecal incontinence. And that can be either because the bowel has a mind of its own and is pushing the stool out when the patient's not wanting it to, or when the bowel does not eliminate in the way that it should and you're not able to get the stool out and it's leaking, possibly partly because of pelvic floor weakness. So same kinds of things can happen with a bowel that happen with the urine in terms of how it affects us, namely knowing where the restrooms are, planning your time around when you eat, and when you do other things. And it can be very embarrassing for people. They worry about having people smell the odor of stool or urine, of course, needing to wear extra pads. And then some people feel the need to pass stool every time they urinate, which is not comfortable or convenient, and sometimes can lead to skin irritation with frequent wiping. So how do we get this better? Okay, well, one part of it is understanding why you're having the problem. And when it comes to fecal issues, stool issues, because I'm not a gastroenterologist, it is very helpful to have the input of one to know what's going on. You know, is it something as simple as a dietary issue, or is it more complex and needing to be investigated, possibly with colonoscopy or other tests? But in general, for urine and bowel, there are lifestyle changes, meaning, you know, not drinking before you leave, possibly diet change, etc. There are medications available, in particular for the bladder I'm talking about now. And about 70% of people who take a medication get significant improvement with their overactive bladder, but 30% don't. And of those 70%, even if they are technically improved, they may not be happy enough. So that's why there are other things that are available, other treatments available that can help get better control. So kind of mentioned these things already. Diet, there's a list of foods and drinks I give my patients when they see me that are known as bladder irritants, which are foods and drinks that are acidic, spicy, caffeinated, alcoholic, and carbonated. And they can both over irritate and stimulate the bladder and the bowel. Exercise, namely physical therapy, can be helpful, but just overall maintaining your well-being and your strength, and having a wellness about you because you have good endurance and you can get out of a chair without difficulty and do some of the activities of life without really struggling to do so. There is a great physical therapy team here at my facility who help me out with pelvic floor patients, pelvic floor issues, where they can teach them how to do either the Kegel exercises, which are squeezing the particular muscles of the pelvic floor involved with the sphincter muscles of the bowel and the bladder, and then trying to get those muscles to be better coordinated. That's what biofeedback is, trying to almost retrain them into working more efficiently and better. So about medications, again, they can be helpful for a lot of folks, but I've noticed over the years that a lot of people aren't happy with them. They're a nuisance to have to take. They dislike taking one more pill because they take a lot already for whatever other reasons. You have to take them every day to get the most effect, most benefit out of them. And then there can be some pretty significant side effects. Dry mouth and constipation are the two that I mention the most to my patients because those are the ones that are most common and have the most impact for people. Blurry vision can also result, high blood pressure for some people. There are two categories of bladder medications. The newer one, which works very well for a lot of folks, isn't so incredibly expensive and so poorly covered by most insurance companies that it's almost impossible for me to get them to try this pill because it's just not affordable. So that leaves the other category that has been around for decades, that also works by slowing the bladder down. But the problem is there's now a concern that they may be linked with dementia. So medications are becoming less helpful and less reliable, which is why I'm really glad there are other options that are available for patients. So kind of touched on this slide already a little bit about how when people get started on medication, they often don't stick with it. Only about 20% in some surveys report being extremely satisfied and continue on with it from year to year. A lot of patients report to me they don't take them every day. And you see there on the slide, about 82% of patients don't take them routinely. And then a lot of patients don't come back to see me if we try medications and they're not happy or they don't help. And that's disappointing because there are other things that we could consider trying, and instead they're going home and just suffering and being very disappointed and not living their lives to their fullest. So if medications don't work, what is there? Advanced therapies, all right? And there are options for the bowel and the bladder. The only treatment that I know that has both bowel and bladder benefit is the InterStim device made by Medtronic, the company that is hosting this webinar tonight. I don't have any affiliation with Medtronic except for the fact that I love their product. I think it has really benefited a lot of my patients when other treatments have failed them. But I tailor treatments based on what the patient needs. So not everybody who sees me goes just for treatment X. It depends on their health, their motivation, what works best for them. So we'll talk about other stuff besides just the InterStim, but in particular, it is a very helpful option for people. Medications can be injected into the bladder as well. That's on the bladder control portion on number 3, namely Botox, which we'll talk about more in a minute, which is right there. Next slide. Botox is a paralytic, meaning it paralyzes the muscle. When we inject it into the bladder wall in an office-based procedure that lasts about 10 minutes, it partially paralyzes the bladder. Multiple injections, usually a total of 20, are injected into the bladder wall to allow this medication to eventually take effect over the next week to slow the bladder down and allow the bladder to hold urine better. It basically blocks the bladder from reacting when it gets too full. And as the slide there indicates, it does block that, or doesn't address the bladder-brain communication. It's not doing anything to the bladder nerves, it's addressing the bladder muscle itself. One of the biggest issues that I warn people about with this treatment, especially in men, is that there's a significant risk of retention where you cannot empty your bladder. It's pretty rare in women that they can't empty and would need to catheterize their bladder. It's actually much more common in men. And again, just because of how their anatomy is much more complicated and the prostate is involved, so more likely to need a catheterize than women are. I tell people the nice thing about Botox is if you want to try it, it's an easy procedure to have done, and it takes effect pretty quickly. And if you have a side effect, like you can't urinate or anything else that you don't like about it, it goes away. The medication wears off. That's also the biggest downfall of that treatment is if you like it, if it helps you with bladder control, it wears off. And how quickly it wears off is really variable from person to person. I've had some people who have great control for 6 to 9 months, only come back to see me once or twice a year for the office injection. And I have other people who see me every 3 months. And then the other thing that's a little frustrating for me too is that sometimes people get great responses and are happy with the result. And when they go in for round 2 or 3 or whatever it is, they're not as happy. And I do the same thing every time. So I can't really explain the variability in response, but that's one of the things that I don't really love about that treatment option. But it's in the office and you don't need to have surgery for it. So it is something that a lot of folks do find appealing. This treatment right now on screen is something I don't personally offer, but I do know something about it. It's a device that will indirectly stimulate the bladder nerve. It's done in the office. It's typically every week for 12 weeks. It's a 30-minute treatment session where you come into the office. There's a little electrode that is put into the lower leg above the ankle and kind of toward the calf muscle a bit. And then over the next 30 minutes, this device is gently stimulated with an electric current. So I kind of describe it as like electrified acupuncture. Not painful, very easy to have done. When you're done, you get up and walk away and you don't have any activity restrictions. But it can take a little while for it to take effect. And it's a lot of visits, 12 weekly visits. And then there's some maintenance involved. And so because I don't have the ability to do that treatment in terms of the time commitment required for my staff, it's not something I currently offer. However, I do think it can be a very helpful treatment for a lot of patients. And so for people who are interested in it, I just simply send them to a provider outside of my facility that can get that done for them. The sacral neuromodulation is something that I do offer here. In fact, I did it last week and I'll be doing it again tomorrow. This is a device that will directly stimulate the bladder nerve. So it basically stimulates the bladder nerve to almost reset the bladder and get it to quit being so overactive. It is done in a 2-step process. There's a trial period where you have a temporary device that is placed, and then we stimulate the bladder nerve over the next week with this device. And week 2, we see if there's improvement. A lot of folks who do take this test get enough improvement, they go forward with the placement. In fact, in the last, decade or so that I've been doing this frequently here at St. Croix, I can count on one hand the number of patients who did not get benefit from it during that week of testing period and wanted it removed. There is a way of placing a temporary wire in the office, but I over time have found that I think it's much more effective and less prone to moving out of place where I put it if I do it in the operating room. So we'll talk about that a little bit more in a minute. So it is a 2-step procedure where we test you, see how you do. And if you like it, if it helps you, great, we put in the permanent device. If not, we take it out. So it's pretty common. 375,000 people worldwide have had this therapy. And actually, a little side note, kind of interesting, one of the original developers is Dr. Siegel out of the cities. I think he may be retired now, but he was integral in developing this program. So kind of a local treatment that's had worldwide benefits. So that's kind of cool, I think. So there are 2 parts to this device. The first one is a wire, and it's coated, it's flexible, it's not sharp, but it is placed into the lower back. Not in the spine, it's lower down. And I describe it in the area to patients basically between the waistband and the top of the butt cheek, kind of in that area, and a little bit off to the side, so not in the center. And it's possible to do this procedure with people who have pain pumps, who have hardware in their back from back surgery, who've had other kind of back operations before, because I'm not in the spine, I'm elsewhere. And the little wire is placed under x-ray guidance to make sure it's in the proper spot and it's stimulating the bladder nerve. We test it to make sure it's in the right place before we attach the temporary battery to the device and then send the patient home for the testing period. And as you can see on the slide, on one study, over 80% of people who had it were happy at 5 years still. The nice thing about this device is that now it is no longer an issue for having an MRI. Several years ago, this device was not MRI compatible, and so it became a big issue with folks that needed MRIs for various medical issues they were trying to get diagnosed. But this is MRI compatible, so you can easily shut it off during the test, turn it back on when it's over, nothing has to get removed. And so it's very easy to continue to live a normal life with this device. So is this something you might want to consider? Well, if you're bothered, absolutely, you shouldn't have to live with and suffer. Most insurance companies require that patients do conservative therapy first before they will authorize the placement of this device. And I think that's a good approach. I mean, you don't want to have surgery you may not need if something else as effective and less invasive is an option for you. But this is a good option for a lot of folks to consider if they have tried and failed medications, if they have tried and failed lifestyle and dietary changes, and they're done putting up with it. They want to do something about it. So according to studies, this does work. It's not just patients telling me, there is actually science behind this, as you can see on the screen. 84% satisfaction rate for bladder control, 3 times improvement in quality of life compared to pills. I believe that's mostly because it's a one and done. You have the procedure to get the device placed. It's pretty much a set it and forget it, and you don't have to take a pill every day. You don't get side effects from the pill. You don't have to keep coming back to the doctor office, etc. And according to a study, 89% of people who use Medtronic bowel therapy experience also long-term success.
Perfect. And now we're going to watch a short testimonial video.
My name is Sarah, and I'm a management consultant, and I'm 28 years old.
Good morning, Sarah. You have some missed calls.
It's a lot of work, and I'm very much engaged in my career and where I'm going, and it's just very exciting right now. When I was about 17, I started noticing more frequency and the urgency coming on, and dealt with it through various forms of antibiotics and just different approaches with diet. And then it got worse and worse. I was really embarrassed when I first joined this company that I had this to deal with, and I actually called it bladderitis. I would get into work and attend a meeting and again be fine sitting down the minute that you stand up. Kind of embarrassing when you've got clients around and you've got to hightail it to the ladies' room. You just always felt like you had to go. It just was not good. It was horrible. So how I was led up to InterStim was through a physician referral that this was the last hope, basically, that I had. And I went in very skeptical, very reluctant, and very closed to this final idea.
The thing I remember most about Sarah is when she came to see me, she was miserable, first of all. She had tried numerous therapies. Everywhere she went, she was being ruled by her bladder symptoms and was controlling her. It was affecting her relationships. She is a professional who travels a lot. It was affecting her work. And when I saw her, she was essentially at the end of her rope. The best thing with Sarah that I remember is when I talked to her about the InterStim, she was so skeptical.
I didn't understand why she was so sure that it would work, but given the high percentage rate, I was very open towards the end of our conversation. Given that there was a trial, I was very secure with the fact that it wasn't going to be permanent, that we could have that trial period. My test stimulation period was interesting. It involved a lot of different changes to my settings to try to figure out which one was going to work, and nothing seemed to be doing the trick until the day before the end of my trial, which was a great success for me because it took a little bit of time to settle in. So after the success of the trial, I decided to go ahead and have the second surgery for the implant, and have had no problem since. I love to run and was only really able to run short distances. Any movement to the bladder was just, would set you off with regards to feeling like you had to go to the bathroom. After InterStim, it's like I never had that problem before. I can stay at the gym as long as I want, and I even ran a half marathon just because I didn't have to deal with that anymore. I think of all of the things, I am the most proud of that moment. 2 hours and 28 minutes and 13.1 miles in 20-degree weather. You know, I did it because of InterStim. I don't think I could have done it without it.
Well, great. At this time, I think we'll take some questions. So just a reminder, if you have any questions from the presentation, use the Q&A box and you can type them in. We have a couple already. So we have, my primary had always told me that there was nothing to be done for OAB. I've had this issue for many years. So I'm wondering what the first steps are to treat this.
Well, the first step would be to meet with a urologist. I'm here full time. I don't come from the cities. I actually live in those communities, so I'm here frequently. It would be to evaluate you to see if you have a history of urinary infections that might be contributing to your symptoms. You know, if there's anything else physically that could be explaining your symptoms that would need to be addressed, say a urinary stone or, God forbid, a tumor. And then trying different treatment options to see what works best for the patient, best for you.
Great. And then this one's related to bowel incontinence. What can I do for bowel incontinence? I experience constipation and take softeners, laxatives on a regular basis. I also have incontinence of the bladder, but it's mostly stress related.
Okay, great question. So when it comes to difficulty evacuating the bowels, that is something I would recommend, if you haven't done already, to go see a gastroenterologist, because it may be something that would benefit from medication, physical therapy. You know, if you haven't had a colonoscopy recently, it should be addressed. I see a lot of patients with constipation and bladder problems. So some of the things that I'm sure you've already tried before, Miralax, prunes, good hydration, exercise, all of those things can be helpful, but that's not enough for everybody. And sometimes other things are needed. But again, that's more, I think, where a gastroenterologist could probably help somebody. Stress incontinence, I don't know if I explained this very well before, but because it's an outlet issue, really the InterStim is not helpful for that condition, because the InterStim is addressing overactive bladder and the urge leakage that happens when the bladder forces the urine out against your will. When it comes to stress incontinence, the coughing and sneezing leakage, weight loss for people who are significantly overweight may be helpful. Pelvic floor therapy, I think, can be greatly helpful for a lot of folks to strengthen the pelvic floor. But sometimes it does require surgery, but the surgery is not something we've talked about yet. That's actually usually a sling procedure where a little piece of mesh is put under the vaginal skin to act as a support system when the patient does movements that causes leakage. So that is something I treat, and I'd be happy to talk to you about it if you'd like to see me in the office.
Okay, so this was kind of a two-part question. So they said, I'm guilty of not taking diuretic, but because I need to be in a meeting, for example, or drive a long trip with others. Can you address potential options or longer-term issues that might raise from this practice? And then additionally, they have a medication to control the incontinence intermittently, but they don't take it because they believe it interferes with the purpose of the diuretic.
Oh, sure. Yeah, I get that question a lot. So diuretics work only on the kidneys. It forces them to put out more fluid than they would through natural means or the other stimulation, like, how much fluid you have in your body or how concentrated your blood is, different electrolytes and whatnot. So the diuretic forces a kidney to spit out more urine than it would. But diuretics do nothing to the bladder, okay? So it doesn't interfere with a diuretic if you take a bladder slowing medication. It just allows the bladder to maybe hold the urine better as your kidneys are shooting down lots more urine than it would already. And I hear this from my patients a lot, especially, hey, I came down from Siren or wherever, and I haven't taken my bladder pill because I knew if I did, I would never make it without wetting myself or stopping a million times before I saw you today. And for short term, that's fine. It's not a big deal if you miss a dose or two or a little bit late. But some people really need to get that extra fluid off their body, because if not, it can lead to heart failure or worsening of their already existing heart failure. The other thing that I hear people tell me a lot is that in addition to doing that, they also don't drink much if they're going to be on a long car ride or whatnot. And if you do it carefully, it's not a problem. But if you really dehydrate yourself, that is a problem, because it can lead to a lot of side effects that are unpleasant or maybe dangerous, like balance issues, emotional irritability, you just don't feel good, constipation, increased risk of bladder infection for some folks. So it can be an issue, but that's where it's nice to know that there are options. So you can take your water pill and you don't have to dehydrate yourself, but you can still maintain, a normal schedule and do normal things without worrying about bladder control.
This one is related to pain medications. Do pain meds add to urinary issues such as like Tylenol or RX?
Tylenol, no. Ibuprofen, no. Anything over the counter should not add to bladder issues. The biggest thing that I've noticed is that medications that are narcotics, or for example, prescription medications for pain, those are highly constipating for a lot of folks. And when people are constipated, it really affects how their bladder behaves. It can either make it difficult for them to empty, especially for men, but also for women, or it can just really throw off, the normal signals to the brain and the spinal cord with the bladder. So that's really the main thing. The other thing too is that when it comes to things that are removed from the body by the kidneys, if you have kidney function that's not normal, drugs that are cleared by the kidneys can be potentially dangerous. So ibuprofen, Aleve, that kind of thing, especially if they're taken frequently, can be very hard on the kidneys, and in rare cases can cause kidney damage.
Great. Next we have you heard how the TENS treatment works for the nerve stimulation?
TENS.
Or TENS?
Yeah, so the TENS that I'm familiar with are the two little electrode pads that you put on your body to stimulate the muscle to contract. It's one of the therapies that people sometimes have when they have muscle spasms for, musculoskeletal issues. As a urologist, that's not a treatment I prescribe. The technology is, similar in terms of the electric signal that you're using with the PTNS treatment that I mentioned I don't do in my office, where it stimulates the nerve. TENS typically stimulate the muscle. So I don't personally know of any application for urinary issues with that device. But it won't hurt you if you use it. It's not going to cause bladder problems if you do.
Perfect. And someone mentioned, I don't really have a question, but I'll make an appointment for an update and to discuss the meds I take. So just want to reiterate too, we do have your number on the screen right now if people want to jot that down, and they can call to schedule an appointment. Continuing on with questions, my OAB has gotten extremely worse since I had radiation for endometrial cancer. Can I be helped?
Potentially, yes. Yes. So when I have a patient with that kind of history, there are some tests I want to do to make sure that the urinary tract is healthy, that there's no scar tissue from the radiation that could have caused blockage, or a secondary cancer, namely of the bladder, that can happen with radiation exposure. But the most common reason is the bladder just becomes more inelastic than it should. It's not able to stretch to hold the urine appropriately. And so you hit maximum capacity much sooner with radiation exposure for some people. So Medications are limited for people with really severe problems from that or other physical reasons to not hold the urine well. So things like InterStim would be an option for you to try, or Botox potentially. So that would be something I'd be happy to entertain. I will tell you that in rare circumstances, the bladder can be so damaged and so inelastic with radiation exposure that the only other option to maintain good capacity or a good amount that the urine will hold is to do what's called an augmentation. That's a major operation, is done rarely because it's usually not needed, but it's also not done in small facilities like mine. That's something that would be needed to be in a big hospital. But the short of it is we take a piece of intestine from the patient and we disconnect it from the rest of the bowels and put the bowels back together again during the operation. But we take the bowel from a loop and cut it in a way so that it's more flat. And then we literally just sew it onto the top of the bladder after we open up the bladder to allow that part of the bladder to stretch more with filling. So again, if you're having issues, you don't have to live with it. Even though I can't offer you that major operation, hopefully you won't need it. And there's some other options I'd be happy to try with you and see if we can get you better.
And then someone has a pacemaker. Are they able to get an InterStim if they have a pacemaker?
Absolutely. Yeah, there's no interference with it. So not a problem.
And then if I have frequent urination because of an enlarged prostate, will these treatments help?
So men are a little special because the most common reason for them to have overactive bladder is the bladder has struggled over years of trying to empty out past the blocking prostate. So sometimes for men, what they need is to be unblocked, to have some sort of treatment, either medical or surgical, to open up the prostate area so it's not blocking the bladder anymore. And when the bladder is not struggling to empty past this blockage, it often will settle down. Kind of akin to putting your thumb over the garden hose. So the bladder has to push harder or generate higher pressures to get the urine out past that blockage. So sometimes treating blockages is helpful. But I will tell you, I do offer Botox and InterStim to men once I've checked them out and make sure they're not being obstructed, and had some great results so far.
This person said, you did a mesh several years ago. I seem to have a harder time to empty my bladder and it takes more time. Can that eventually be redone?
That would be a great thing to talk to me about in the office. So sometimes as we get older, our bladders work less well. One of the things I worry about is, could the patient be blocked from mesh? But if that were the case, that's usually something that happens right away. It's not something that develops over years. So I'd also want to make sure there is no mesh that's exposed into the urinary tract, because if there is, sometimes people can develop a urinary stone on it that can cause blockage. So since you've had surgery before and you're having issues, I think it would be a very good idea to get checked out and see if there's something that needs to get addressed and figure out how to go from there.
What's the insurance coverage like for InterStim?
That's a great question. And unfortunately, I'm going to give you a lousy answer. I don't know. Everyone's insurance is different. Different plans, different coverage, et cetera. So the process that happens here at St. Croix is, number one, if they want to know a dollar value, I get them in touch with the billing department or sometimes a person we call a patient advocate. And they're basically a liaison between the patient and their insurance company and our hospital to figure out, number one, what the coverage is, and number two, what is the estimated cost for the procedure. I will also tell you that when I put someone on the surgery schedule, they go through prior authorization with their insurance company. So no one gets surgery unless the insurance company is aware of it and authorizes it. So they say, yep, this is appropriate, proceed, and it should be covered. But when I'm a patient and I'm wondering if something is covered, same thing for you, we want to know, is it paid for? I don't know that because, sometimes they cover it partially and we're still stuck with a bill at the end of the day for certain things. So that is definitely something we could figure out for you before you commit to having the procedure. But I can't give you a short answer right now for that. Sorry.
Follow up to that is it covered by Medicare?
I have plenty of Medicare patients who've had this procedure, so I know that it is approved for Medicare. But again, the end of the day, what do we see as a bill as a patient? That is something I would have to see for, or let's say for the billing department to help us out with. I can tell you, I don't have patients come back and telling me that they've been stuck with a horrendous bill. That they thought it'd be covered better than it was. So that tells me it has to be covered well for most patients, but how well, I can't give you a dollar amount. I'm sorry. It's a long answer to a short question.
Can you see the device under the skin?
Only if you're really, really thin, because you cannot see the wire. The battery device that stimulates that wire, I call it almost like a thick Oreo cookie. So it's about that size, about yay big. And I put it under the skin far enough that when you put your hand on it, you can see it. And you may see a little dimpling, a little lump that's there compared to your opposite side, but you cannot see it through your clothes. And it's not something anyone is going to know that you have unless that part of the skin is exposed to them or you tell them.
In addition to that, Dr. Nunes, can people have problems with intimacy?
Not related to this device.
Mhm.
Is that what the question is?
Yeah, they were wondering if it was visible or if they'd have problems with being intimate.
No problems being intimate. No. The only concern that I've ever had patients tell me, especially for folks that are really thin, so they don't have much fat back there, is that if the device itself is too close to the skin level, when they lean up against something firm, like a hard chair or a wall or something, and they press against that device with their skin between the wall and the device, then it can be uncomfortable. But sexual activity, intimacy, not a problem for this device.
And then can you swim with the device inserted? And what about the battery?
Great question. So part one, yes, you can swim with it, but not the first week that I place it because I do a two-step procedure for this placement. So step one, week one, people go to surgery, they lie on their tummies in the operating room, and they usually get IV sedation for the anesthesia. It's so heavy that they're knocked out completely, but most people don't need a breathing tube to have the anesthesia be safe for them. Excuse me. And I do the placement with x-ray guidance. I like to joke with my patients the day of that first operation that I'm very picky. So I want to make sure I get the wire in exactly the right place to give them the most benefit for the procedure. So sometimes it happens that it's a really short placement because I get it perfectly right away. And we're talking maybe 15 minutes of surgery. And other times I'm finessing it and trying to make it better. And it just takes me a little bit longer to do that. Excuse me. And then during that week, after they wake up and go home, the week of testing, they have to sponge bathe, unfortunately, because you can't get the temporary device wet, but you can go to work, you can live your life. It's not super restricting. And then week two, if the patient gets benefit, we take out the temporary part, put in the permanent part. And in the rare circumstance they don't do well, we take out everything while they're asleep. So it is two procedures back to back on their tummy with IV sedation. But after that week of healing, when the device is permanently placed, you can do whatever you want. Excuse me again. A little dry tickle, too much talking.
All right, and then the last question that we have right now is, this male was diagnosed with MS a long time ago and had their prostate taken out 6 years ago. They have had bladder and bowel problems for years. Can anything be done for me? I am 77 years old. If so, it would be worth it. Thank you.
Yeah, so MS is a terrible disease. It can cause a lot of different problems. And the problems can come and go. So what one patient has one time doesn't mean that they're going to have it 5 years down the road. This device, especially if it's bowel overactivity, can be potentially helpful for you. I will tell you that a lot of patients who've had their prostates removed have leakage of urine because the sphincter muscle is not strong enough to hold the urine in place. And so physical therapy is sometimes helpful for those patients to regain pelvic floor strength to have that sphincter muscle work better. But MS can often cause overactivity. where it pushes the urine out so forcefully it can't hold it. So to know if you benefit would require a trial with that device. Excuse me.
Perfect. Well, those are all the questions. So thank you so much for hosting this event with us tonight, Dr. Nunes. It was extremely informative and we're so grateful for your time. And thank you all for joining with us. Again, please jot down the phone number for their office so you can schedule an appointment. Much of what was discussed tonight is relevant to a lot of you, but each person is unique. So it's super beneficial to schedule an appointment and talk through all your options. And then one more question, since it just came in, is there an age limit on the InterStim?
I would be reluctant to do it on children, primarily because I don't treat children. But other than that, no. I mean, if you are elderly, but you're active and you'd like to be more active and you're not because your bowel or your bladder are holding you back, yeah, I'm happy to offer you that treatment. There's no age cutoff.
Perfect. Well, with that, we will end this presentation. So thank you so much, Dr. Nunes, and thank you all for joining us tonight.
My pleasure. Thank you for your time, guys. I appreciate it.